Good morning. Trust we're all well. It's a good thing that the rain waited until 3 o'clock. So I must say, a little bit of a correction from what was in the newsletter. Mark is unable to join us this morning, so I will be giving his presentation. He added my name to it and deleted his, but this is his presentation. He did all the work, all the research on it. And then in the second hour, I will be talking about, at a more personal level, my life in global health. So please don't leave at the break. Hey, it worked. So USAID, United States Agency for International Development, was established in 1961 by President Kennedy, one of my childhood idols, and under the Foreign Assistance Act of '61. It was later codified under a Foreign Affairs Reform and Restructuring Act in 1998. So until that time, it had kind of existed as an executive order. 65 years. I wonder if President Kennedy imagined it would last that long. Its purpose: to end poverty, foster democracy, provide humanitarian relief, where it focuses through health, education, good governance, and economic development, with emphasis on health. PEPFAR, sorry for the pop, is the President's Emergency Plan for AIDS Relief. It was established by George W. Bush. And PMI is the President's Malaria Initiative, also established by George W. Bush. And democracy and governance, and economic growth, including energy, clean energy. Strategic goals: to strengthen U.S. economic reach. I bet you didn't know that its purpose was to expand the U.S. economy, to strengthen U.S. foreign policy, to promote low-emission, climate-resilient world, to protect U.S. interests by advancing democracy, human rights, sorry for the no-ass, civil society, and to modernize diplomacy and development. U.S. foreign aid, the total of foreign aid. The U.S. budget, $7 trillion. The total of foreign aid, $71 billion. That seems like a lot of money, doesn't it? But look what it is in terms of a percentage of the U.S. budget. Puny. And of that, USAID's share is the $38 billion, which is less than 0.4% of the federal budget. That's half the cost of one F-35. Jeez. And the thing that you also have to note with this is that the vast majority of that budget is spent to procure U.S. goods and services. So we're not giving it away to them, we're investing it in us. Where does it go? Well, you see, mostly it goes to humanitarian assistance. That includes food aid, health care, democracy and governance. Administration is only 10% of that. And that includes, all of the paying of all of the local staff and all the missions around the world. And other various sectors, such as energy, such as agriculture, Yeah. Okay, you may have heard a while ago, this agency got put on the cutting block. In 2022, USAID had 3,100 direct hire employees. Today, there's 295, from 3,000 down to 300. Most of the staff that work for USAID are contract staff. In 22, there were 12,000 of them. In 26, less than 50, fewer than 50. What about the budget? Yeah, used to be 30 billion, as we saw before. Now it's 1.2 billion. On July 1st, thank heavens it wasn't July 4th, USAID agency is terminated. Again by executive order. Yeah. You'll forgive me, I'll have some moments here of deep sigh because this is personal, as you'll see in the next presentation. So, what are we looking to do? Looking to have a positive economic impact and expand access to our markets for us, to expand our trade, to promote inclusive economic growth. Unlike in the US, where all of the economic growth occurs in the top 5%, we want to promote more equitable growth in the developing world. And of course, reduce extreme poverty. And boy, let me tell you, in Africa, extreme poverty is pretty poor. And improve general food security. What about our strategic challenges in foreign policy? Well, we want to build a stable Middle East and Africa. I don't know about Iran, but and in Asia and Pacific area to improve the security and prevent and respond to crises around the world and provide humanitarian aid, to overcome diplomatic challenges worldwide, and to strengthen resources to global health, which we'll be talking about in the second presentation. Promote a transition to a low-emission world. I bet you, those of you who maybe knew something about USAID didn't realize that USAID was also involved in energy. Promote energy security, Power Africa. It just so happened that the mission director in my last post in Kampala, Uganda, had been the director of Power Africa before he became the mission director. And then just transition to a cleaner economy globally. Democracy, human rights, and civil society. We want to encourage democratic governance, not dictatorships. That's overseas, of course. We want to promote stability, peace, and prosperity. We want to promote human rights. Provide bilateral and multilateral engagement. There are many worldwide organizations and structures that we participated in. I want to make that past tense. Strengthen civil society through democratic governance with local capacity. Modernize diplomacy and development. Enable diplomats to influence and collaborate more freely. Enable diplomats to influence. So our soft power facilitates the role of the State Department. To have development professionals, such as USAID contractors, operate more efficiently. and effectively, and maintain a broad, respectful international relations. Some outcomes in the health sector. Accredited by WHO, the World Health Organization, 4.5 million lives saved per year. 4.5 million. It is operating in over 20 countries with 6,200 separate contracts, grants, projects. Malaria alone, the President's Malaria Initiative, saved 6 million lives. 67 million children vaccinated per year. That's probably more than in the United States, especially recently. 92 million premature deaths over its history. This quote from Oxfam America's president: "There's not a single area of development and humanitarian assistance USAID has not been involved in." Yeah, sometimes you get in the line of a bullet. All the places USAID operates are not necessarily peaceful. I myself was evacuated twice. 99 staff have been killed in the line of duty. There was a wall of honor set up in the former USAID office in 1965, where the name of each fallen, killed employee is listed, kind of like the Vietnam Wall on the mall in DC. It was dismantled in 2025. The offices of USAID used to be in the Ronald Reagan building, and so when they ended USAID, they had to transfer this wall somewhere. Um, 83% of 6,200 programs ended. 94% of staff were laid off. Still an agency enacted by Congress. So since it was established by Congress, it can't simply be eliminated by executive order. At least it didn't used to have to be. USAID work on transferred to America First Global Health Strategy. You know, if you remember back in the previous slides, you'll see there's a lot of America First in those objectives and visions. The Food for Peace, 97 million, down from 1.2 billion. The food that is provided in Food for Peace is sold by American farmers. It's a subsidy to U.S. agriculture. And of course, you know, training has been reduced by over 90%. And the Global Disease Surveillance Network is dismantled. It used to be we participated along with WHO in doing disease surveillance around the world. We got information from countries because we were USAID, providing them assistance. Now that we're no longer a member of that international arrangement, we're not going to get the data. Or if we get it, it's going to cost us a lot of money. And since we've abandoned all the governments who are providing the information, they probably won't be all that interested in sharing it with us. like to show this video, before we start that going on, I just wanted to say that, you know, over the 60 years since USAID was established back in the day, it was really the only source of development assistance funding. But over the decades, a lot of foundations, a lot of NGOs have provided considerable funding to development assistance, such as Gates Foundation, Clinton Foundation, and et cetera. So what you'll see now is an attempt by some very brave people to do something about it.
When the U.S. Agency for International Development shut down, more than 80% of its programs were canceled. In an attempt to keep the most cost-effective and life-saving projects up and running, 2 laid-off agency employees created a website called Project Resource Optimization. It matches donors with threatened programs. So far, they've helped keep nearly 80 projects running in 30 countries. Ali Rogan sat down with the founders, Caitlin Tulloch and Rob Rosenbaum.
Thank you both so much for joining us. Caitlin, first to you, what was it like when you realized that USAID was going to be essentially shutting down? And what were you the most worried about happening after that?
Thanks, Ali. It really was a tumultuous time earlier this year. I think initially we were trying to figure out what the impact of the executive orders was going to be in terms of future programming. And there was a belief that there would be future programming. USAID would continue in some way. But after not too long, I think you could really read the tea leaves and understand that the agency as a whole was going to be shutting down. And I think the scariest part of that, the part that really a lot of us had to spend a lot of time sitting with and processing, was that when you knew what USAID had been doing and the importance of some of these programs for global health, for survival in crises around the world, the thought of that just blinking out was really, really scary.
And Rob, as somebody inside, as this all was happening, we heard many advocates for USAID saying this is going to lead to instability, hunger, deaths. But as people who are watching this very closely, what have you seen in terms of the impacts on the ground?
Unfortunately, that is starting to really bear out. And unfortunately, I don't think that we have seen the sort of full effects of this. Many of the outcomes that the programs that USAID was set up to support take a long time to actually come to the fruition. Immunizations that are not being met, those have lifetime consequences for children. But where we are seeing kind of the most immediate impact of this is in humanitarian settings, where health and nutrition services are not reaching children who desperately need them.
So Caitlin, tell me a little bit more about that. What sort of programs are you connecting funding with? And what is your criteria for basically picking which programs you're going to seek to connect to new sources of funding?
As we understood that actually everything was at risk, I think that forced us to do a really terrible triage and focus on programs that we knew to be life-saving. And that meant mostly programs from USAID's humanitarian portfolio and its global health portfolio. I think the kinds of programming that we're looking at, as Rob mentioned, it's immunization for children under 5, helping keep kind of global infectious disease burdens low. And we saw in 4 or 5 countries programs where the vaccines had already been procured, the technical assistance to help strengthen the government's outreach and delivery of these vaccines was planned, and then overnight the plug was pulled. The other one that weighs heavily on my mind, I spent a couple of years working on treating children who are facing acute malnutrition. This is, at risk of starvation. That usually happens in humanitarian settings, places like Sudan. And so you saw the supply chain for things like this ready-to-use food that helps keep children alive, all of a sudden being shut down, things being locked in warehouses.
Rob, now you have funding through your platform flowing back into projects across 30 countries. What does that look like? And was it difficult to get some of these programs back up and running once funding had been paused?
Our approach has really been to try to figure out in a really rapid triage kind of an approach. What are the programs that are delivering the most impact per dollar spent? We call this cost effectiveness in terms of saving lives. And we were able to do that because there's a huge amount of evidence out there, of research that's been done to understand what are the interventions and the ways that programs are delivered that can lead to these types of outcomes. And so we went out searching for the programs that we understood were going to be delivering the most impact per dollar spent, to reach out to those programs to really understand what they were doing, and then to use that information to try to crowd in private capital and private philanthropy to pick up some of those pieces. We had a few donors at the beginning who kind of helped us build some momentum and get this thing going. And as time has gone over the last 8 to 9 months, we've seen more and more people kind of come up and step forward and say, hey, this is something I really care about, and this is a really important thing to do.
You've used the word, Rob, sticking with you a few times, triage, which indicates an emergency situation. Is there a point at which this no longer becomes an emergency operation and it becomes something that is a little longer term? Are there plans for that at this point? What does the future of this look like?
The bottom has not fully fallen out on this in terms of the long-term consequences and the impact of what's happening. And unfortunately, I do not think a lot of the funding that has currently been cut is coming back in the next year or two. So we've been working really hard over the last year, again, to triage these projects and to find those that we think are kind of most need of urgent funding. We are continuing to do that from now through the beginning of next year. We are kind of doing a last mad dash to say, are there any projects that have met our criteria that we may have missed, and rapidly kind of assessing them and getting them onto our platform to bring more funding in. And then as we move into the new year, I think we're really moving into a new phase of this thing where we are focusing on what is the design of programs that really can lead to the most impact per dollar spent, and how do we continue to work with the partners who are delivering this work, who have been delivering this work for many years now, to help them streamline their programming, continue to do it at the highest possible level, and then continue to bring more and more private philanthropy in to help fill some of these gaps.
Caitlin Tulloch and Rob Rosenbaum with Project Resource Optimization. Thank you both so much.
Thank you so much, Ali.
Yeah. Okay. That didn't take as much time as it was supposed to take, but maybe you have tons of questions or comments.
Hi, Brad. Mark did a really good job of illustrating what a small part of the U.S. budget this aid is. But one story that probably he could have done a better job telling is, and maybe you can weigh in on this, how much of an impact does that aid have on the countries that were being helped by the program? Is it 10% of their budget? Is it 50% of their budget? How much of an impact is it having on those countries that are now not benefiting from this program? These programs, many programs.
I don't have a statistic for that. We could go find it, but just give one example where one of these multilateral organizations that was established in the 2000s was called the Global Fund for AIDS, Tuberculosis, and Malaria. We were a major contributor to that, but we also, in our law, we said we can contribute no more than 30% of the total contribution from all countries together. Most developing countries try to spend about 6% of their budget on health care, but yeah, Mark, I don't have a good But yeah, the elimination of these will create big problems in terms of, WHO was already estimating the number of deaths that will occur because of it. Yeah. Great question, not a good answer.
I think it's really I'm Janet.
I know you.
I think it's horrible that all this got cut, and I'm grateful to all those who have stepped up to try to fill the gap even a little bit. My fear is, and this will come to a question eventually, my fear is that the people who justify cutting this are going to say, well, look, we didn't have to do it with government money because private money's stepped up. Is that a fear, and do you think that's going to be a problem if and when politics shift back to the more generous side?
Well, the amount of the USAID budget, it's going to be tough to replace that. We were in more than 100 countries. You notice the video, they were talking about trying to focus in 20 and to focus essentially on emergency situations, right? People living in refugee camps, that sort of thing. But the basic overall national structures that USAID would build and support, those are, and also, July 1st, which countries are, not in the middle of their budget cycle. It's like they have an excess pot of money sitting there to move in to compensate. So no, things will crumble. And having spent a long time building systems, it takes a long time to build a system. You can destroy it in a day, but it still takes almost the same amount of time to rebuild it. And even as I was saying, let's say we come back, let's say Democrats take Congress and they decide to impose the budget. We're no longer trusted. What you're building is not just systems, but trust. And when you say, it's hard to say, come back and say, oh, I'm sorry, that was just an anomaly. Yeah.
Hi, Debbie Robinson here. And Brad, we've had a couple conversations about your background, which is so fascinating. And I'm wondering, as an epidemiologist, I can tell, or I inferred, that you're concerned about that lack of data that you will not be receiving from countries about, various diseases, et cetera. I wonder if you could elaborate on a possible argument for people that are so concerned about everything needs to be me. Is there an argument that would work to really help them understand how those activities actually do help them? It seems like many people are so short-sighted. How do we convince people that are not aware of this concept?
I have no idea, is the honest answer. They're eliminating information systems in the U.S. as well. The Centers for Disease Control and Prevention is castrated. So yeah, there's, and they say, of course, they'll just do, individual country information systems, but they won't. They won't. It would cost way too much. When you're getting all the data you need because you're participating in a system with other donors and governments, you're paying a third of what you would have to pay if you're doing it by yourself. You're getting the data, and it costs you much less. And besides, governments, why would they give us their data? We've told them we don't care about them.
Hi, I'm Lisa. And I was wondering if perhaps the reach of USAID became too wide, and that could have been a reason that there was inefficiency.
How do you define inefficiency? I think they were very efficient. At least when I was managing the money, we were very efficient. Yeah. Was their reach too wide? Well, remember the strategic objectives. So we gave aid not because we're just good-hearted. We gave aid because it advanced our economic, diplomatic interests. And it was also good for the farmers. You know? Remember, our food aid was purchased from U.S. farmers. So, and not each of those 100 countries also were necessarily involved in all sectors. Okay? So we wouldn't necessarily have a full USAID mission, mission being the USAID mission in Kampala. Okay? I don't know that our reach was too far for the purposes of the agency. Yeah.
Brad, this is Fred.
Yeah.
I was wondering if any other nation, such as China, has stepped in to fill the gap that we have left.
China has a different strategy in development assistance. If it's profitable for them, they'll provide it. The terms of their loans, they don't give like we give. So they may step in to fill a gap, but it could be a short-term solution for the receiving country, but eventually they'll pay the price. It's just a different strategy, different philosophy. They don't have the white man's burden.
Hi, my name's Ann, and thanks, Debbie, for your question about epidemiology. I think one of the underlying things that Debbie was getting at is how do you convince Americans that this actually benefits America as much as or even more than people in other nations. I mean, in terms of economic development, healthcare, and things like that. So if we look specifically and only at the food subsidy, the farmers' subsidies, what's going on with American farmers now that they don't have that income? And what's the long-term impact within this country?
I don't know. Yeah.
It is a rhetorical.
Yes. I figured that. Yes. I know you. I didn't know. Yeah.
Hi, this is Vicki. Like Humpty Dumpty, it's impossible to put things back together again. As it hopefully will come back in some form, how do you see it coming back? Do you see it coming back as USAID or being dispersed among different agencies? What do you see coming back first? Is there anything that you see not coming back at all?
Well, if it comes back, and if it is going to try to be a multi-sectoral agency because it's trying to meet U.S. interests in many different areas. Okay? It would kind of have to be USAID again. I think the argument for emphasizing the economic growth activities, because they are directly related to us being able to sell products to the country, has a particular leverage incentive. The health thing is, you know, when the next pandemic, and there will be another one, you know, if we're not doing anything to help them, then it's going to come here faster and with greater vengeance. So, you know, stopping it there or reducing it there, it helps us to have less of a brunt. The democracy and governance sector, I think, is perhaps one that if anything disappears, it would probably be that. You know, democracy and governance, USAID started to get involved with that sector at the fall of the Berlin Wall and the disintegration of the USSR. Previously, you could be a dictator, you could be a thief and be president, and so long as you were giving us access to your markets, it was okay. We could live with that. Once USSR disappeared, we no longer needed, you know, you to say you're pro-West. So it's then that we were emphasizing good governance and democracy. Where if, in some instances, where if there were a military coup d'etat, USAID would suspend activities there. Yeah.
Hi, I'm David. A quick check on the country of Sudan, where a very large amount of USAID money went. Between 2024 and 2025, the country of Sudan cut their budget on healthcare in half. So it went from about 2% to 1% of their budget. 90% of their budget actually goes to military expenses. During that, in 2024, the U.S. government was the primary donor to Sudan through USAID for humanitarian efforts, and we provided them $800 million. The entire budget of Sudan for 2025 for healthcare is $6.5 million.
Yeah. Yeah. I would posit that may be at one end of the extreme in terms of those ratios, but yeah.
Hi, I'm Helen. Excuse me. The only criticism
A little closer to your mouth, please.
the only criticism that I've ever heard about USAID was from a diplomat stationed in Colombia a few years ago. And what that person said is the USAID trucks would come in to the villages, and that was awesome. They would excuse me, they would drop off the supplies and then they would leave. And then the local communist folks would come in, collect all the stuff, and go to the villages and distribute it and take all the credit. And so I'm wondering if that was something that happened, and is that why maybe American politicians weren't entirely happy with USAID if they heard stories like that? Or should we focus on taking credit or not, or just have it be a humanitarian circumstance?
We always take credit graciously, without, in your face. You look at U.S. food aid, and you will see in large letters, USAID, gift from the American people. We don't necessarily take credit when you're out in some village and they're doing childhood immunizations, because that's not us doing that. We work at the national level with the ministries of health. They do the actual vaccinations. So either, but we also have contracts and grants with a lot of U.S. as well as local NGOs who do the work for USAID. And yes, we do watch to make sure that branding is correct. There is a policy, and if you do not brand, you may not get your money. Yeah, so, I think that the people that we work with at the ministries, they know that it's us, but we don't necessarily always try to tell the mother of the baby getting vaccinated who bought the vaccine. Yeah. But I don't know about that particular instance. I think that was probably not typical. So not typical from my experience in Africa or Haiti, anyway. Yeah.
Mark, what happened? You're not first.
He was.
I was first, but I'm not allowed to ask a second one. Oh, my goodness, I might have just forgot my second question. I did, Brad. I forgot my second question.
We'll just
I
make one up.
apologize. I'll ask you during the break. I'm sorry.
Just make one up.
Hi, I do have a second question. I was wondering how much education of, mothers who have a lot of children is one of the focuses of USAID, and do you think that that's important?
Yes, probably one of the most important factors for child survival is birth spacing. So if you don't have access to contraceptives and you get pregnant every year, the effect of that on low birth weight and infant mortality is considerable. We do a lot of work with family planning, reproductive health generally, and family planning particularly. It's most unfortunate, too, that millions of your tax dollars that were spent to buy contraceptives were never delivered in the country. Because the day it ended, you cannot spend your money to deliver what you had purchased. Yeah.
My name is Jane, and I was a nurse in the earthquake medical groups that went to Haiti in 2010. And just to refer back to what someone said about Colombia, in Haiti, we had nurses and doctors coming from all over the U.S. and Canada. And I was in charge of pediatrics, and the most disturbing thing that we found was that I was six months after the earthquake. I was there, and we had just moved into a cement building that was going to be the hospital because it had been intense on the tarmac. And we had to each have someone that spoke the local language go out to the streets and buy supplies like IV fluids, IV start kits. And these were things that had been donated. And so all these donations came into Haiti after the earthquake. They were put in warehouses near the airport, and we had to purchase them. If I needed to start an IV on a baby, someone had to go out to the street and purchase that. So I just wanted to share that story.
Yes.
Brad, this is Don back here. I apologize in advance. I do not have a question. I have a very quick comment. Hindsight is a wonderful thing. Perhaps if the folks at USAID, right after it was apparent that Trump had won the election of 2024, if they had renamed the organization Trump Aid, then there never would have been those cuts.
Yep, that sure would have been the Trump card.
I believe this will be the last question.
Thank you so much. My second question. You alluded to birth control. Another aspect of this, of what I was reading about was, and your comment please at the end, is that many girls who were going to school no longer have that privilege because they're trying to gather food. And your comment about how the education of people, I mean, we're all here, so how that negative effect will also be negative for the entire world.
Yes, the most important factor for child survival, I don't want to say the most, is girls' education. Yeah.
Okay, I guess we'll take a 10-minute break and come back at 11 o'clock.
Dear members of the Willamette Institute for Continued Learning, okay, to segue from our discussion of USAID generally, I'd like to spend this time on a more personal note. Guess what? Brad's life in global health. So I want to give just some biographical information and address the question of how the hell did Brad end up in global health? And then kind of focus discussion on three particular areas where it was my privilege to work, basically on child survival, on HIV/AIDS, and on the eradication of guinea worm disease. And my apologies for me not having the proper format for this, and we're hoping that it'll be okay. Gwen-Ellen reassures me it'll work. Where I worked, on what and for whom. How I ended up in global health. Then three areas. The Integrated Management of Childhood Illness, IMCI. HIV/AIDS, I think I don't need to define that acronym, and the eradication of guinea worm disease. What did Brad work on? The design, implementation, and evaluation of a wide variety of health programs. HIV/AIDS, child and reproductive health, disease eradication, healthcare financing, surveillance systems, and supply chain management, to name a few. Where did Brad work? Well, I was 10 years in Zaire, Democratic Republic of Congo, 4 years in Haiti, 4 years in Mali, 6 years in Senegal, and 5 years in Uganda, along with some other countries around Africa. India and Kazakhstan are the only countries I worked in Asia. For whom did Brad work? Well, as you'll see in a moment, I started out in Peace Corps. I worked for USAID, I worked for USAID contractors, I worked for the Centers for Disease Control and Prevention, and I worked for the Carter Center. My formal education. So I have a BA in International Studies from the U of O. I have a Master of Public Health in International Health from Tulane University with the concentration in epidemiology, and a Master's of Business Administration from Heriot-Watt University in Edinburgh, Scotland, with concentration on organizational development, OD. How did I get into global health? Well, I always kind of knew from maybe the 8th grade that I wanted to do something internationally, but I didn't know what. Whether I'd be a diplomat, whether I'd be a lawyer or a businessman, or development. As you noted, I got my BA studying international relations and spent a year at the University of Poitiers, where I got to meet some Africans for the first time. And my main international relations professor was also an Africanist. After graduating, I joined the Peace Corps. What do you do with a BA in international studies and you're not ready to go on for a master's degree? You join the Peace Corps. I was assigned to Zaire, former Belgian Congo, presently Democratic Republic of Congo. At Peace Corps training, I was originally assigned as a water and sanitation hygiene volunteer because of my experience building houses with my dad. That qualified me to build latrines and dig wells. But because of my French, I got reassigned to open a sub-regional office of the National Immunization, Diarrheal Disease, and Malaria Program. Then, when I'm about ready to take my assignment, this Belgian cooperation person who had been the regional supervisor in a region the size of France, ticked out. That's when in foreign service, if you don't get promoted after a certain number of years at your grade, then you are retired. So, yeah, she got ticked out, and guess who got assigned to the regional supervisor job? It was in Lubumbashi, still called Lubumbashi, and there was a U.S. consulate there. Now, that gave me an opportunity to meet diplomats and to meet international businessmen. That was important. Because on my day job, relative to what the diplomats did, I got to be a big fish in my pond. That was important for me. Yeah. However size the pond, I want to be a big fish in it. I never had to promote an idea in which I did not believe. What diplomat can say that after 40 years in the State Department? And I got to spend my time working on something that was both challenging and rewarding. Not bad. The question of my youth, what should I do, was resolved. Now I'd like to tell the story of 3 areas where I worked: in child health, HIV/AIDS, and disease eradication. So, in the integrated management of childhood illness, okay? What is that an integration of? Well, lots of things, and it changed over time. It expanded over time. In the 80s and 90s, so smallpox was eradicated in 1980. It was certified eradicated. So, and WHO then moved on from there to develop the expanded program on immunization. Then there was a movement to integrate, to add malaria and diarrheal disease activities along with immunizations. USAID funded a contract called Combating Communicable Childhood Diseases that was implemented by CDC. It was actually on that CDC implemented CCCD contract that I worked as a Peace Corps volunteer. Ah, yes, BCG. It's a vaccine to prevent tuberculosis. It's administered in infancy. We had procured a little bit more than we were able to consume, so we didn't want to waste it. So we decided we would lead this catch-up campaign in local elementary schools. The weekend before, the Sunday before we were going to start this campaign, God revealed to some ministers that the Americans would be coming into schools to sterilize our children. Boy, I'll never forget the image of all these kids when this American kid comes up in the vehicle and gets out and they start unloading the cold boxes. Those kids certainly obeyed their parents that day, and they ran home. Yeah, so anyway, I guess, God works in mysterious ways sometimes. Then we also added, in the 90s, the acute respiratory infections to the algorithm. Pneumonia, not heavy. In the Central African Republic, we would train nurses on this new algorithm so that they could easily diagnose and differentiate cold and cough from pneumonia. There are evident, clinical signs to differentiate that. But we kept noticing that even the trained nurses didn't seem to be able to communicate with the mother that their child is severely ill and needs to make sure she takes this medicine. They just wouldn't do it. They could obviously see it, and they would prescribe the things. Finally, we came to understand the ethnography of that is if you tell a mother that their baby is really sick and may die, which you need to tell her because you need to emphasize this is not funny, and that baby dies, you are associated with that death. You had foreknowledge of it. Therefore, either you cast the evil spirit or you knew who did cast the evil spirit. So, in the 2000s, we added perinatal. Neonatal is the first 28 days. And we extended some IMCI services out to rural communities beyond the health centers, into community health huts, where they were executed by community health workers. The question I had in Senegal when this was being introduced was, will the community health workers respect the protocol? If they are properly trained and supervised by the nurse, will they follow instructions? And of course, what we found is that actually the community health workers followed the instructions 100%. The doctors and nurses do not. They know better than the WHO. So once we demonstrated that they would use it, we were able to expand it around the country and in rural areas. A couple of ironies. I landed in Africa to join the Peace Corps in Bujumbura, Burundi, that airport. My last short-term assignment in HIV/AIDS happened to be in Burundi, in Bujumbura. Kind of midway through the time there, I wasn't feeling well. And I was thinking, oh my God, have I got COVID? That would be embarrassing because I've been in the mission every day and, I hope I didn't cough on anyone. But no, it was malaria. Now, I had been working on malaria, among other things, for almost 4 decades. Never got it. Until the last month. The mosquitoes had their revenge on me. After spending a lifetime killing them, they got me back. Karma. Andando. A couple of friends of mine got into a tasting room of a local winery in Turner and saw a brochure for an organization that was working in Senegal. They told the folks, gosh, we have a friend who just moved here who worked in Senegal a long time. He might be interested in this. And so I met with the folks, and they mostly work in agriculture, local gardens and forestation and stuff. And I said, hey, if you all would be interested in expanding your activity in IMCI, community IMCI, I would love to provide some technical support and of course, financial support. They took me up on my offer. So, isn't it weird, Community IMCI, Senegal. I started Community IMCI in Senegal. And now there's some organization in Turner that works there. And now I'm going to become their health program advisor. Yeah, so, strange things happen. Did it work? Well, when I started, there were, of every 1,000 newborns, live births, 110 did not reach their first birthday. 40 years later, only 44 did not. I think a 60% reduction. Not bad. HIV/AIDS. After my Peace Corps job, I got a job with USAID in Kinshasa working on the family planning project. And we had a lot of relations with the CDC NIH project, also working on HIV/AIDS. At the time, we had no tools. We had this test called ELISA, and you had to collect 100 samples before you could run the assay. And most people who had the courage to come and give their blood never came back for their results. But the test positivity was very high because you wouldn't go and get tested unless you were kind of sick, right? You know, these later stages, AIDS, before you get tested. We only had AZT. And as a monotherapy, as only taking one medicine, it really didn't work very well. And so it would prolong your miserable life, but it wouldn't really get you back to health. Prevalence among commercial sex workers, about 30%. And of course, at the time, use of condoms with commercial sex workers wasn't common. All the modeling would require an array of like 5 laptops to generate the math needed to do the models. The conclusions were all the same. Implosion. The continent was no longer going to exist. Well, it's a piece of real estate, it might, but Ngoy was a colleague of mine. He was in charge of supervision. We would often go out on field trips to see our project's activities in different cities. And I noticed that Ngoy seemed to have a girlfriend in each city. And I asked Ngoy, do you use condoms? I mean, we did have the national supply of condoms about 50 feet from his desk. No. What? With all the meetings we're having with CDC and NIH, you're not using a condom with these ladies? No, because using the condom would show that he's concerned that he might have an STI, a sexually transmitted infection, or that he was weak. Well, about 5-10 years later, I get the news. No more Ngoy. In the 2000s, after I finished in Mali on guinea worm eradication, I had applied and been accepted into Johns Hopkins University to do a doctorate. On my visit to the campus, I was staying with a friend with whom I had worked in Haiti, and she got a call from a fellow that I worked with who had been in charge of the project that I was working on as a Peace Corps volunteer. And he was inquiring to see if I would like to come to Senegal to be his deputy director and technical advisor on AIDS and child survival. I didn't really have a good impression from my advisor-to-be. And boy, those other students in the classroom, they sure looked young to me. I was an old man. So, there we go, back to work. I arrived in Senegal 2 days before 9/11, just in time, as it were. There have been important changes over the years. First, there was developed a full range of antiretroviral drugs. So monotherapy no longer. 3 or 4 different combinations we used. And we developed rapid diagnostic tests so that you could go and give a little sample, little drop, and you would know your status within 15 minutes. So you didn't have to go and come back to learn your results. In Senegal, we were trying to develop a network of service providers for commercial sex workers and MSM, gay men having sex with men. And of course, because for those kinds of patients, you need to have somebody who's very sensitive, is going to treat them properly, or else they won't come back. The Senegal Ministry of Health was fairly liberal for a primarily Muslim country in Africa, but Dr. Wad, the man at the Ministry of Health in charge of the development of this network, could not tell his uncle what he did for a living. they were sinners. (2020s). Test and treat. So basically, it used to be that you would commence treatment with ARVs only after a certain immune system cell, CD4, reached a low level. Then they would initiate. But now, in this time, we started to treat as soon as you test positive for HIV. We began to monitor viral load as opposed to CD4 levels. So you could tell, how well the antiretroviral drugs were working, because you would count the number of viruses per unit of blood. In this sense that effective ARV treatment reduces your viral load so low that you can no longer transmit. So in this case, treatment became prevention. And there was the slogan of 90-90-90. 90-90-90 means that 90% of the people with HIV know it. 90% of those are on antiretroviral drug treatment. And 90% of those have suppressed viral load levels. When you get to that point, you have what's called epidemic control. Do you remember the word implosion? It's not the same thing. And then the nice thing about this is that, people with HIV on treatment could lead normal lives. They're no longer dying of AIDS. Might die of a car accident or something, but that's not HIV's fault. Did the program work? 2000, which was the peak year, 2.7 million new cases of HIV in sub-Saharan Africa. That's a lot of people. 9% of the population was HIV positive. And in some countries, a third of adults had HIV. Botswana, for instance. 2025, 650,000 new cases. 75% reduction. It's not bad. Over one generation, the application of these two technologies had reversed what was to be the implosion of Africa. Thank you very much. Who knows what guinea worm disease is? Wow, that's more than I was expecting. Oh, Kathy, this is my cousin. You don't count. Of course you know what it is. No. So life cycle. It's basically a 12-month period. It does annually, right? So larva from the worm gets into water. A water flea inadvertently swallows the larva. The larvae do some molding, and eventually somebody drinks the water with the water flea containing the mature larva. Goes into the stomach, the male and the female do their thing. The guy, since he's now fulfilled his life's purpose, dies. She traverses the stomach wall and starts to grow in interstitial space. About 10 months later, she's got larvae ready to lay. So she emits a toxin that creates a blister that's very painful. people to relieve the pain have a tendency of getting into water, the same water that they drink. So she gets to lay her eggs in the water again from where she came, and then the water flea eats them, and off we go again. And again, it's based around the rainy season, so it's kind of an annual life cycle. Guinea worm is old. It's been around for a long time. There are reported cases of it from ancient Egypt. You all have heard about the plagues. Is that Exodus, I guess? Well, there was one plague that was boils. Boils. Well, those boils probably were guinea worm disease. She had emitted her toxin and it created a blister. There is no treatment for it. Since it lives in interstitial space, you can't transport an antidote. Okay? You can't get it there. But there are 3 ways to prevent it. It's called case containment, basically preventing the person with emerging worm from going in and cooling off in the water. Okay? There's a product called Temophos. Abate is a brand name. It's a chemical that is used to treat the water source and kill the copepod, the water flea. There's filtration. It's kind of a nylon little tissue that is used to, pour your water into it. The water flea can't get through the filter, and so you can't get guinea worm from filtered water. In 1986, the campaign begins. 3.5 million cases in 20 countries, mostly of Africa. In 1991, a military guy by the name of Amadou Toumani Touré conducted a military coup d'etat to oust the then president, who had been found guilty of murdering students for protesting. He was promising elections, a return to democracy. It's the first instance in post-colonial Africa where a military leader did that, promised elections, and delivered. So, the guy who got elected, he had to be inaugurated. And Carter wanted to come, was invited to attend the inauguration. While he was there, he said, well, I'd like to meet with Atete. Great. During their meeting, Atete asked him, well, what does a former president do? Carter said, well, you could join me in the eradication of guinea worm disease. But he says, I don't know anything about guinea worm. He said, don't worry. I'll set up a secretariat and assign you an advisor. I was that advisor. The advisor to one former president and the employee of another former president. That's pretty presidential, don't you think? Yeah, back in the day there was kind of this debate, among folks, who would be first or who would be second to eradicate their pathogen? Would it be polio or would it be guinea worm? In 2009, there were 388 cases of polio and had spread to 9 neighboring countries. Why? Well, God, again, revealed to some religious leaders that, guess what polio vaccines does? It's the Americans coming here to sterilize our kids. Polio? Anyway, that rumor got around, And, but in 1990, there were 2.5 million cases of guinea worm, the highest in the world. 20 years later, Nigeria had 0 cases of guinea worm disease. Did it work? Well, in 1986, when the Carter Center became involved with guinea worm eradication, there were 3.5 million cases in 20 countries, as I mentioned earlier. In 2025, there were 10 cases in 3 countries. And Mali, in 1923, had 0 human cases. Did it work? Yeah, not bad. There you go. I guess I can pick that back, but I forgot the slide that says, does anybody have any questions? Now that everyone knows what guinea worm is.
Hi, Brad. Thank you very much. It's fascinating. And thank you for what you did. I had heard of the guinea worm stuff, of course, because of former President Carter's involvement. But was this funded primarily by the Carter Center and money they raised, or was there government money as though we still had a U.S., well, of course, in those days we did have USAID. So what was the funding for this program?
It was mostly private. You know, 90% were private funds. Yeah. Some countries, like in Mali, for a short period of time, we did have a grant from the USAID mission, but it was more of a gesture. You know, when you got the former president in charge of the operation, you don't want to tell him, we don't care about your guinea worm. So, you know, that soft diplomacy stuff.
Brad, what happens to the person that had the guinea worm infection? I mean, aside from the boil leaving, do they still have worms in them, or are they free of them once the boils resolve? Can they have it for the rest of their life, I guess?
Once the female lays her egg, he will die. So the life cycle is a year one, and their lives are. Of course, the guy kicked off, you know, much earlier, but she will die. Yeah. And you know, just kind of on that too, is that back in the days, right, before the eradication program began, also when someone got guinea worm, they would get a lot of worms. You know, the thing is 3 feet long, and you could have, you know, 40 things going on in your lower legs. So guinea worm didn't kill people directly. What it did, though, is during the rainy season, when they all needed to go out and tend their fields, they couldn't walk. So they're more likely to die of starvation, just because, you know, and when you have, you know, the entire community infected, because they're all drinking from the same source of water, and the cycle, you know, just kind of repeats. Yeah.
Hey, Brad, I'm over here. I'm Virginia. Spent 35 years working with Rotary, which was involved with the NGOs, the non-governmental organizations, and the Gates Foundation, eliminating polio.
Yes. Eradicated.
Yeah. Almost was the last. Yes. You know, we're talking about things that you could count on your fingers and toes around the world for free polio cases. But it's the same kind of problem that polio ran into, or the Rotary and the Gates Foundation, that the religious people who said, don't trust these folks, they're out here to sterilize our country.
Yeah.
How did the people that you worked with overcome that? Because it was definitely something that the polio vaccine process got involved into.
I'm not sure I'm understanding the question. In terms of polio eradication, how does that program deal with the claim that it's going to sterilize the kids?
The same kind of mentality for the Guinea disease as well as Rotary, the polio process. You have to counter that. And was there a method that you found worked to counter that message from the religious leaders who were a little weird, but okay? Yeah.
Okay, but vaccines there is no vaccine for guinea worm disease. There is no opposition to, case containment, to water treatment, to filtration. Okay? You have to educate and inform the population about how this guinea worm gets to you. But it's pretty simple. It's mechanical. It's visible, and it's observable. If you have a village of 100 people, and last year 80 of them had guinea worm, and this year they started to filter their water, and 3 of them had guinea worm, you observe it. The thing is ugly when it comes out. It's 3 feet long. Thankfully, it's thin, so it's not like. It comes out extremities for the most part. Okay, lower legs, and hands and arms. Because remember, it moves after it mates, right, in your stomach. She moves into interstitial space. She's not in your blood veins. She's not like in muscles. She's kind of in this area between. Yeah.
Hi, Brad. Fascinating presentation and talk. I had a related question, actually. I thought about the Gates Foundation because we read a lot about they're going in and targeting things like HIV or malaria, I think is a more recent one. Is there an overlap of services, or do they come in and work with organizations? How does that, do you know how they come in or what they do?
Yeah. It's not, sometimes the foundation will fund government. Most times it'll have an organization, right? It'll have an office in a country. It'll have a representative. And it works, with the national programs, it works. Yeah, there is an overlap because we're all doing the same thing, but it's not a redundant overlap. It's a complementary. And this is kind of the problem with, the disappearance of USAID, because these organizations weren't funding the entire shop. So now when that funding goes away, it's not that they can necessarily replace all of it. You heard in the video that they're focusing on 20 countries. USAID was at 100. So, yeah.
Brad, this is maybe kind of a follow-up to the question over there, is that when all those kids followed their parents' instruction and ran home to avoid being sterilized or whatever, what happened then? Were they able to convince them to come back, or how was that dealt with?
When we left, yeah. Once the American wasn't there with his vaccine, the threat was removed. Yeah.
And then were they vaccinated then?
No. We had to destroys some vaccine. Yeah.
I'm Kathy. I'm the cousin.
Yeah, this is. Oh, by the way, yes, this is my cousin Kathy.
Well, that's not why I'm standing
And
up.
that's my big brother right next to her.
What
So,
I'm
so be nice to them.
I think the question that keeps coming up, Brad, is
Yeah.
that I think the question that keeps coming up, Brad, is
Now
that
we hear ya.
what do we do? What did y'all do when you were working with people who believed their ministers or whoever rather than you? Was there any? Did you have anything? Any protocol? Any way of talking to people to get them to change their minds?
Well, I mean, it wasn't me doing that talking. It was the local government people who would try to talk to these communities, try to talk to those ministers or imams or whatever, right? And the problem with saying that polio vaccine sterilizes kids, right? Is that they've been using polio vaccine for quite a long time, you know? And a lot of people with polio vaccine have kids. So just by observation, you know, without getting into, you know, immunology, you could show communities that, you know, yeah.
This has been great. Thank you for sharing all this. I'm wondering, did you see an evolution of society, you know, like from the early days where you said if you even knew about a baby or could predict a baby dying, then you were an evil spirit? Like, what's been going, what did you see happen in Africa or anywhere you were?
Well, you know, the proof is in the pudding. And when you have reductions of infant mortality at that level, people begin to understand that their fears may not have been true. And you know, these little instances, I mean, they're short-lived. You know, people don't believe for a long time that the polio vaccine is going to sterilize their kids. That shock coming from the religious authority, you know, they don't disbelieve it immediately, but they do eventually. On the ethnographics of it, of spirits, evil spirits being the cause of things, that does still exist, you know, especially with, you know, what is a virus anyway? You know, we don't know. and so when you try to explain to somebody, you know, how a vaccine works and why it works, it's, well, we had that experience with the COVID vaccine, you know, but over time and with observation of improvement, I think societies begin to change their perception of these prevention things. And certainly with HIV, boy, AIDS was ugly. You know, AIDS was ugly. And so now that you have persons living with HIV and they look like, I don't know, don't even have a virus, don't even have a head cold, you know? Yeah. Communication, but mostly observation, I think. Yeah.
Debbie, again, thanks for bearing with question number 3. I have tried to alleviate fear of COVID vaccine. And what I think, before we think we're more advanced than the continent of Africa, people were really, really worried about messenger RNA and all of the scare tactics of it's going to affect your DNA. Would you comment on that, please?
I don't know. But if you don't know what DNA is, and you don't know what mRNA is, you don't know, gosh, Mark, how many bonds are there in DNA anyway?
3.5 million, a billion, 3.5 billion.
Okay. mRNA is brilliant. Brilliant. It can be so adjusted. We don't have to grow the virus. We can just get something that will look enough like it that your immune system will generate something called an antibody, and it'll be close enough. It may not be a perfect match, but it'll be close enough. Unless, am I mistaken on that, Mark?
No, you aren't. I was just going to add, mRNA, it actually programs the ribosome within the cell. And so that's not part of the DNA, that's not in the nucleus of the cell.
Yeah.
mRNA actually programs the ribosome to produce those antibodies. And that over time, that mRNA actually degrades and goes away.
Yeah.
And so our mRNA vaccine for COVID gradually goes away because our DNA is not sending signals to that ribosome to reproduce that at such a great rate.
Yep.
And so it really has a far less influence than, say, a killed virus would that would actually change your DNA.
Yep.
It's
Yep.
not changing your DNA.
Yep.
So that's a fallacy that people often have about mRNA, that somehow it's making some permanent change. It's actually a very temporary change, and it's not permanent. So.
Yeah. And the nice thing about it too is you can easily adjust them each year, right? To depending on how that actual virus has mutated, right? But again, if you have no knowledge of genetics, if you have no knowledge of what is a virus, and that was kind of the fundamental problem of why we could never develop a vaccine for HIV. All right, because we would have had to use HIV. Yeah.
Brad, Brad.
Yes, hi.
So my Peace Corps experience included, NGO groups, and one of them was about HIV, and this was in 2004.
Where were you?
I was in Kyrgyzstan.
Kyrgyzstan.
Yeah. And my experience wasn't the vaccination portion of it. I think the Kyrgyz, because of their Russian, were pretty well educated and on top of it. What I encountered is that my brother was HIV, and I assisted him until his death. And I was there, in the house, cooking, cleaning, eating on the same plates. I understood what it was not going to affect me. But so they were impressed when I said that, because they said in Kyrgyzstan, families will, ostracize or throw people out that are sick. They'll just leave them, abandon them. Did you ever encounter any of that kind of attitude?
I don't know if I actually observed abandonment, but it was more, there was a fairly long period of time where people were afraid that you could get it by eating from the same pot of food. You can get it from touching the person. And so there was kind of a wish to more isolate and avoid contact with a person, but I don't know if I directly experienced, and maybe this was, the African family, is pretty tight. So, it's not that they don't abandon kids from time to time, but you have this extended family, and so it kind of pulls together. But the problem with it too is it was just so ugly. You're emaciated and just wilting away. Because you've killed all of those cells that are there to protect you and to develop antibody. And yeah, tuberculosis was the main cause of death from AIDS. Yeah.
My brother was the medication.
Yeah.
Medication, he was on a clinical trial.
Mm-hmm.
So he didn't die of AIDS.
Oh.
He died of AIDS therapy.
Yeah. Yeah.
Okay. We got last question coming up.
Mm-hmm.
Hi, Virginia again. I guess this goes to the future, but has there been any improvement in malaria and tuberculosis prevention and treatment? Is there any kind of vaccines or anything for either of those diseases, which are still ravaging millions of people around the world today?
Yes. Remember the story of the Central African Republic and the nurse that wouldn't tell the mother that their kid could die? A colleague from CDC was in Bangui at the time. She was seconded by CDC to WHO to work on the malaria vaccine. I haven't followed since my retirement, but I suspect that the trial is now complete. Its preliminary results were very, very positive in terms of preventing malaria. But I don't know the status of that right now. The other thing that happened with malaria is the development of a more effective drug. And again, doing a combination therapy. Rather than just one drug, you have multiple drugs in the pill, was also very much more effective at treating people who had malaria. So yes, malaria has made tremendous progress. Yeah, all those lives that were saved were because of that combination therapy and rapid diagnostics. You didn't have to go to the lab to see if you had malaria. There was a little skin prick. And it always helps too, because sometimes people would tend to treat something that felt like malaria when it wasn't. And that only increases resistance to the drugs. So proper diagnostics and quick treatment, and effective treatment, have made a considerable difference. And killing the mosquitoes.
Okay, let's thank Bob.